Good morning, everyone, and welcome again today on November 30th, live from New York at Mount Sinai. Welcome back to our next session of our CCC Live Cases and our Peripheral Live broadcast. We welcome you to this this end of the year, this holiday season. Hope everyone had a happy and healthy Thanksgiving with their family. And with that note, I think we'll just jump right in here. You have no major announcements besides the fact that Christmas is upon us, so it's our second to last of the year. So, PK, what do we got? But you're mute.
Dr.
There it is.
I'm muted, guys. Okay. So first of all, Raman, I'm very excited to have Dr. Cameron join us here virtually. Haroon, thank you so much. I know you're very busy. Dr. Cameron's about one of our members of our vascular team, endovascular team here at Sinai, and as most of you remember, he was our fellow here many years ago, and it's a pleasure to have him here with us to give us insights. Dr. Guja, as you know, is out on vacation, so that's why he's not here. But it was really, we want to first of all thank everyone's understanding for not being able to do the live case over Thanksgiving, understandably, because obviously, you know, it's the day before Thanksgiving, so none of our patients wanted to come. The second thing also, Raman and Haroon, is that our live case that we had planned took Coumadin. So unfortunately, you know, we could not, you know, we'll bring him in with the Coumadin and the INR being high. So we scrambled and we got a pretty interesting live case thanks to Dr. Cameron. And this case is a very interesting case. So I'm going to have Dr. Moeen Syed present it. But before that, I want to introduce our team. To my right is Dr. Vishal Kapoor. As you all know, he's the Director of Vascular Services at Mount Sinai Morningside. To his right is Moeen Syed, who is our endovascular fellow, and Moeen has been a pleasure to work with this year. Behind me is our eternal Ray Lascano, who's always been with us as a pillar of strength. And then we have Elizabeth, and we have today Damien. So we've got an incredible team to get this case done. Moeen, you want to go ahead?
Yes. Can we have the slides up?
Yeah.
So welcome everyone. So I'll get started with this interesting case that we have here today. We have a 72-year-old gentleman who's referred to our PAD center for severe right lower extremity claudication that has been progressing for the last 6 months to a year, and now he's having rest pain in his right lower extremity classified as Rutherford class 4. He's been managed conservatively with maximal medical therapy, and he's been undergoing a community-based supervised exercise therapy. In terms of his past medical history, the usual suspects for someone with PAD, he has diabetes, hypertension, hyperlipidemia, chronic kidney disease stage 2. His creatinine is 1.5. He has known PAD, and he has had a prior left lower extremity intervention at an outside OBL where they intervened on his left SFA and posterior tibial artery. In terms of his social history, he's been a long-term smoker for over 15 years, and he continues to smoke almost 2 cigarettes a day, and he's working on trying to quit smoking. In terms of his medications, he's on, in terms of relevant medications, he's on Crestor 40 milligrams, and he's on silostazole. He's on aspirin as well, and for his hypertension, he's on enalapril and hydrochlorothiazide and metformin for his diabetes. In terms of his vitals, nothing remarkable here. He's doing pretty well. And pertinent vascular exam, he has 2+ DP and PT bilaterally. In terms of labs, hemoglobin 14.7 and creatinine 1.5, and his LDL is pretty well controlled at 65 milligrams per deciliter. His non-invasive evaluation, he did have a resting ABI prior to his left lower extremity intervention. This was done at outside clinic. His right ABI is 0.25 and left is 0.3. And this is prior to his intervention that was done outside. Arterial duplex in the right lower extremity showed absent flow in the mid and distal SFA and monophasic flow pattern in the proximal SFA, proximal PT, and proximal AT. So here we'll go ahead with showing some angiograms, and then we'll discuss the case
I
plan.
want to show you, Haroon. I mean, you know, that the ABIs were done with this QuantaFlow thing. which I think is overestimating the ABI. This is his left SFA. You can see he has
Intervention.
patent intervention site with 2 vessel runoff. It doesn't really look like a 0.3 ABI there, but regardless, the guy is very symptomatic. I did speak to him. He's very symptomatic. He really wants his right leg done. And his right leg, you can see his left leg feels much better since the intervention. His right leg, as you can see, iliacs are fine, good inflow disease. It looks like possibly a nub, I'm not sure. And we probe it a little bit better. And then I think you'll have a nice distal reconstitution zone. And I want to talk about options for these guys, these long segment SFAs, and what is the approach to these patients. So, you know, he's got a nice reconstitution zone there, and he's got 2 vessel runoff to the foot. He's quite an active guy. We've discussed with him about stopping smoking. He's bought on that for sure. He's ready to do it. But the point now is revascularization of this SFA. So what we did is, next please. What we did is we went ahead and we probed ostium, as you guys know. So we took a vertib catheter and we injected. Excuse me, I have a little bit of a cold, and you can see that. He has a collateral coming off at the level of what we think is the ostium of the SFA. And so we took multiple different areas and views. So our plan here, Raman and Haroon, I mean, is to probe this from the proximal, and then if not, convert to a direct SFA access at the level of the thigh, come back up and recanalize. And then I think the real challenge is going to be the therapy and how we choose. And in today's day and age with PQ bypass available, you know, and other things, I mean, what are the options for this therapy? So as we cross, why don't you guys discuss on what you may do? And Vishal and I, our plan is going to be to try a straight stiff glide, our usual methodology. We're not going to waste time with the 014 system here. Try to poke through. We poke through. Hopefully we cross in 5-10 minutes, and then we can get to the work. If we have trouble, then we'll switch to distal access. But why don't you guys discuss how you would handle this if you were doing the cases?
Yeah, so I have a couple points. I think one of the first things that you said, I think, is probably one of the most important. You know, at the end of the day, your physical exam is probably your most reliable. You know, getting a 2+ DPPT, and then you get ABIs are 0.25. I mean, there's something discordant there. You know, I think I think knowing the technology that's available in your diagnostic testing is very, very important, because at the end of the day, if you feel the pulse and you're feeling the patient's pulse and not your own,
it's kind of like
then you certainly are going to be having some.
Kind of
you'll have some more accurate measurement. Now the other point I just want to make, I mean, at PKF, I think we've done these cases in these antiquated fashions very, very often, and you know, as it is the holiday season, maybe we try something different. And maybe what if we this time, instead of saying we're going to try integrate and see how it goes, just so we can show everyone what a direct SFA axis looks like, and kind of show a plan just for the sake of the case to do the entire case as a direct SFA axis.
Well, there's also a couple of things here. I think one is, if you see here a little dive, Vishal, we seem to be at the crux. I don't want to be at the crux of the. Let me see, little dive there, Vishal.
Yeah, 1 second.
Yeah, I just jam it in there. Yeah.
Yeah, so that's better right there. So I mean, at the same time, Raman, I mean, I agree with you. But I think, you know, if this goes, it goes. If it doesn't, it doesn't. Let's see what happens here. You know, I don't want to make a science project out of something that we don't need. Excuse me, that we don't need to. Vishal, you're gonna have to talk. Okay.
Spent a lot of time at a Macanudo last night.
Yeah. So I think that PK is exactly right. I mean, we have to keep to our basics and the strengths. And here, like we see, we're trying to go antegrade. There are multiple alternative options, like PK talked about. But of course, it's always good to probe anteriorly, like we're doing right now, from the ostium, and see if we catch up.
Yeah. All right. So now this is an interesting, you know, kind of a flexion point. This guy he's relatively young. He's healthy, and you know, out of all the patients from Best CLI, this guy kind of does fall into that. What are your opinions on putting this patient, as assuming he has a patent venous graft, to go directly for a bypass here? Arun?
So in my opinion, I think you have to give him a chance of the endovascular therapy, right? So I think my approach would have been like PK and Dr. Kapoor are working on now, is to try to get it from above. And then if that fails, then you have a good 2 vessel runoff to the foot. So would be a good candidate to approach it from the tibial
Yeah,
axis.
I think Raman, I mean, you're right. I mean, surgery is always a good option. In this case, he's more like a severe
Better.
claudication approaching rest pain.
I mean, he
And-
definitely is a severe claudication. I
Correct.
spoke to him yesterday in clinic. I mean, he's
Right.
claudicating quite a bit. I mean, there's no question he's an active young man.
Just to clarify,
Good
the Moin, the presentation, did it say class 4 or class 3?
Class 4.
Class 4, it says.
Yeah, he's progressed to rest pain now. Yep. So he's
A little poke, sir.
So you're right. I mean, in this case, especially if you can see from technical aspect, the degree of calcium, all the factors which might prevent a good endovascular result were like, severe calcification, poor reconstitution, poor outflow. In this case, that are not the factors in this. So I probably at least give an endovascular first approach, a given attempt. Hopefully we cross through and then we do it. But you're right. I mean, vascular surgery, is it an option? It is. But we usually want to reserve it for patients who are presenting more with worsening 4. This is 3 approaching 4. I would probably do 4, 5, or of course 6 for sure. And then, like you said, there are other options like PK talked about VQ bypass and all the stuff, which we can obviously talk about.
Let's just talk about the technical aspect of direct SFA access. So what you first want to do is obviously lump it up. You can do it on ultrasound, but generally I do it under fluoroscopy. You give some dye, you lighten it up, and then what you want to do is try not to move, sir. What you want to do is go ahead and try to just line up the needle on top of the vessel. So the needle's on top of the vessel here. So I know I'm on top of the vessel because he didn't move at the time. And then what I'm going to do is I'm going to go to a contralateral view, and then I'm going to have Vishal just give me a maggot up here a little bit. Sir, try not to move, sir. And then this will tell me the depth of my needle and how to go. A little dive, Vishal.
Yeah.
So we're right on top of the vessel here. And now we're just going to go to the depth of the needle and see. So we're already interacting with the vessel there.
What wire do we need?
And then now we should be in. Nope, we're not quite in. Little dive.
Just bounced out.
More calcified than
Than I'll be expected.
Well, I'm a little high too, so I don't have a lot of running room here, but
there.
Now I'm in. So now that I'm in, so you can see the flow in the vessel. And so it's just one poke. So remember, you want to be in the anterior view, you want to be AP, and the lateral view, you want to just be this one. So I'm just going to push this in as much as I can. And now I'm going to loop it, and then I'm going to get my micropuncture sheath in.
So, PK, do you have a thought process on how much normal segment length do you give for
Well,
having
I mean, I'd like a
wire
little
and
more
access?
than I did there, but
Right,
I mean,
that's
I think at this stage it should be okay though.
Yeah.
So
just
once we're in,
for everyone watching, the point about the remainder of the normal segment that is being made right now is you can see the amount of purchase we have of the wire in that distal SFA in the retrograde approach. You remember at this point there is quite a bit of muscle, tissue, fascia that have to kind of go through. So
now you see what happened. I bent the wire.
Exactly, because in the end of the wire
There's another one, please.
typically more
Stiff micro.
If you go with the dilator, you may be able to get back across in exchange for a different wire. Go with like V18.
Well, it's pretty calcified here, Raman, because clearly you've got a very calcified vessel here, because definitely it should have gone through. I had a good loop there.
Also, just for everyone else watching, this is like not that easy of a technique. PK made it look a little bit too easy.
Yeah, I was gonna say.
I mean, usually it takes
does a lot. So
I mean, not to say that it cannot be done. It can be done. It's just a little bit challenging. Also, this is also a very good kind of problem that has to be overcome that we see very often in other issues.
we lose.
Trying to deal with the actual bent wire inside the body without losing your actual lumen. So what they're trying to do is pull.
We're going to lose access.
Looks like it. Yeah.
It's okay. It's just the
wire. All right, we're going to have to restick. No big deal.
Yeah.
All right, give me the wire again.
Yeah, give me a new wire. Give me a new micropuncture again, please.
Yep.
Yeah.
One
So
more.
I'm going to go a little lower this time, Raman.
Yeah, makes sense.
Yeah, so that's exactly what we're talking about from the technicality, is trying to get as much purchase as possible, so that way at least we
sometimes,
Not the stiff one I had.
And sometimes, if you're lucky, you can actually even with your Australian wire or the wire that comes with the actual microaxis, you can actually knuckle it a little bit and get a little purchase.
That's what I tried to do.
Occluded segment.
Yeah.
This time it wasn't really as.
No, I tried, Raman, but I guess I was too proximal.
Yeah. I think you're right. You can dissect it, knuckle it with this wire, get some more purchase, and go.
All right,
we'll go back to our.
Let's go AP again. Again, you want to go AP.
Just have both of them ready.
And you want to get on top of the vessel. Little
roadmap.
dive.
One
Just
second.
a little dive.
No roadmap. Okay.
No
dive,
roadmap.
fine.
Just to see.
Sure. with your hand.
Now again, remember for everyone watching, there's a theoretical concern of, like perforated issues, but remember this is an occluded segment. You're going to reaccess it, and you're going to end up at some point doing some form of a balloon tamponade. You see a little bit of contrast extravasation right now, but this is a manageable amount that was going to be able to be dealt with in the in the subsequent steps after crossing. So this would not be something that is quite alarming. We just kind of watch it, monitor it,
hang on.
and see where to go.
More lighter. Yeah, and I think one important point is in this case, the body habitus is favorable, so he's not a big leg. Remember, we're trying to go out a vessel which is entering the adductor canal, so it's trying to go more posteriorly. So you have to really open the thigh up, actually evert it, so that way, we don't tuck the toes up. We just keep the leg thigh open as much exposed as possible, like you can say here.
Give it to me in the big needle.
And then we try to get access. So that's what PK is doing.
Big needle.
Yeah. Now, just for the sake of asking, what's the plan for? I guess why direct SFA and not pedal for this case?
Well, it's interesting, Raman. I mean, I think we could have done pedal, but I think direct SFA is reasonable here, just because we have a nice landing zone. Okay, a little die now.
Yeah, right. I mean, Raman, that's a good point of talking about alternative access. So yeah, pedal is one of the options as well, like you said. Two vessel runoff, PT is occluded, so we could technically get an AT and do it from there. But I think with this, we'll have more pushability and more direct getting our devices up there. And we anyways have a sheath up and over, so we're going to work eventually through the main 7 French system. But here you can see.
See, we're quite far away from this approach. See, the needle's not even reaching.
Yeah, because trying to get more posterior, so it might have to go a little bit higher up.
A little higher up because it's dropping posteriorly.
Correct. So that's what I was trying to say. Is just remember the vessel is going back. Yeah. So that's where PK is losing the length on the needle itself. Almost, I think on this side. Okay.
Now we got to go to another view here, a little die. We were in already. Raman jinxed me by saying that we were in.
Now it the vessel.
Nope, little die. I was right on top of it before. That's why I went more proximal. I'm not on it. See? Nope. My approach is off. See, this is the approach you want right here.
Yeah.
Little die.
The track, yeah.
Nope.
Oh, right there.
But I think I'm in and out. Here, give me the wire. So deep.
Yeah, you seem to go a little bit further.
And
again, also for people who haven't done this very often, same thing that you see with the tibial axis. That usually once you puncture the actual vessel, it's very common that sometimes you'll catch the posterior action, the posterior aspect of the vessel wall. So sometimes just having to pull back is really all that you really need to do.
No, I'm not in the vessel. See, I'm just
you're still on the outside.
It's still outside.
Yeah.
Hey, I'm not reaching, Raman. That's the problem.
Yeah. The other thing which you can consider is
give me
go with the V18 exactly. Yeah, right.
Give me a V18.
Right off.
They don't have they have a command 18.
V18. Okay, give me the command 18. No, I'm not bleeding. It's not coming out.
Yeah, no.
Nope.
We have to take
it's so deep right now. Okay. So we're gonna have to go higher up again.
So, Dr. Krishna, I have a question. So, what makes you choose a fluoroscopy over a ultrasound guided?
I mean, for direct SFA, I think fluoroscopy is the way to go. Honestly, I really do. I mean, it's worked. Like I said, I got in 3 times already, and we're just not able to reach, which is surprising. Let's do a roadmap here. Inject.
I mean, it all comes down just to the sheer anatomy of the vessel. By this portion, it starts to go more and more posteriorly.
Try not to move. Okay, right here. I'm going to go straight vertical now.
Yeah.
This is going to be interesting. It actually almost looks like there's a small... I can't tell whether that was there before.
Okay, now give
me the wire.
Yeah.
Right there.
Yeah. They don't have a V18. That's the problem.
Okay. Command 18. We're looping.
Yeah.
Don't move, sir. Sorry. Nice. Oh yeah, go baby, go. Yeah.
There
I'm
it
just
is.
trying
Good.
to loop it as much as
A
I
little
can.
bit of purchase. Good.
Yeah.
That's really all that we
Let
really
me give you
need.
the dilator first, just to make a track, and then I'll give you the whole sheet.
This is the dilator.
Yeah. Watch
Yeah.
the sharp. So this time, we're just being extra cautious by starting with the dilator or the micropuncture first to create a track.
Yeah.
Okay.
Because the issue really just becomes was when that wire gets bent. Because when the
Yeah.
wire
Well-
gets bent within the body, then getting anything beyond the kink in the actual
Sure.
wire becomes quite a challenge. So I think going with the dilator
Hold
to
on.
avoid that is going to be pretty helpful in avoiding that problem.
Yep. So now we're gonna go in.
I know you have a nice
Yeah, we
amount
just
of
put
purchase.
Now we're
There
in.
it
one
is.
Now
system.
we're in.
Yeah,
Perfect.
that looks
So
very,
that's
very
just
good.
the dilator or the micropuncture.
Now the wire's not coming out. Jeez. There it is. The wire's out now. Okay. Now let's see.
Yeah.
No, this is just a
All right. Let's get the
sheet.
sheet now.
Yeah.
Uh-huh.
Good.
So you can see it's not as easy as it looks, but we're gonna try here. It's a very calcified vessel, and then we're gonna go with a now the question is what wires do you want to use, Roman? Once we're in.
Yeah, honestly, if the one that's in this position in the retrograde approach, my first wire choice, nearly 100% of the time, is almost always the V18, because it has a nice hydrophilic body. Sometimes
again.
makes its way. Oh boy! If you pull the wire into
So
the
let's
sheets,
do this.
maybe
Put
you
the-
can
Now
get
it's
it
in.
back. There it is. Yeah. Oh, there's a little bend
No.
in the wire again.
Yeah.
That
Hold on.
little
Let me
kink.
put the dilator back in.
No, man.
Good. Perfect.
That's just called brutal there. I was just brutal.
Yeah.
I just pushed the damn thing in.
Right.
All right, now give me the
Good.
V18. Give me the we don't have V18.
I'll start
Give me the 035 this one.
Live wire?
035 glide.
Okay.
Why don't we have a V18?
Yeah,
Why-
it really
why-
is. It's such an effective wire. At least out of all the ones in our closet, it's one of my favorite ones to actually cross retrograde.
Right.
'Cause once a stiff body forms the knuckle, it goes up so nicely. Now the question is this, PK. Oh, at what point would you say that now you have this? You have which wire is this?
This is
Is
the
it
035
the-
glide. Now put a torquer on this. I want to try.
Yeah.
So the question is, do you want to lose the knuckle and just push it up now?
But yeah,
know?
Or
I
do you
guess
wanna-
my biggest.
Would you go
Yeah,
with
go to
a
torque.
crossing catheter now? Because
Well,
you don't really have a lot of purchase.
But
at
you know,
that
but right
ostial
now
segment.
I just have a little sheath, right? So the point is, are we going to put a 656 slender in here or not? Is the question, right?
Yeah. I think the
bareback
biggest.
it.
Yeah.
Yeah, we could.
Well, the biggest question really is like the ostium. Remember that we
'cause
reconstitute right
you
at the
really
ostium.
have to exactly. You have to cross
Yeah.
right at the actual knuckle.
Yeah, I mean that's the biggest
Right at
issue
the
for
entrance.
anybody who's doing this is to make sure that when you're going
Is he okay,
retrograde
Ray?
like this, is like not jeopardize your CFN profunda like PK was talking about. So I think that's the biggest concern. Is like we love to dissect, but then at some time you have to really re-enter as well.
So then we should put a 5/6 slender then.
yeah, I would, and then we can balloon tamponade from inside once we're up and over.
Or why not just try to
Cross.
just
Cross.
bareback a
A microcatheter,
yeah,
Like what? You want to bareback a
Oh, 035,
you wanna
a
bareback
a Navi cross.
Navi cross.
Yeah.
Why would you want to
This is a
bareback it? It's the same. 035 Navicross is what, 4 French, right? It's a 4 French. So what you can use a 5/6 slender. It won't matter anyway.
Sure.
So give us a 5/6 slender here.
5/6 under.
Maybe in that case, just use a 4/5. It'll be even
Or
smaller.
a 4/5 slender, even smaller. 4/5.
4/5 slender.
4/5 slender, even smaller.
Yeah.
The issue with the slender is that it has the dilator is not 035 compatible.
You have to change the dilator to a regular
So
dilator.
give us a regular dilator here, guys.
Yeah, he already gave.
Well, the other thing we could do is, since we're from below, we could go with the 5/6 slender, and we could put a supera at the ostium and do it that way too. If we cross at the ostium, that's another thing we could do. But let's cross first, and then we decide all that. You know, Polena and those guys in Italy came up with that technique of putting the supera from the popliteal retrograde access at the ostium. So we could always do that as well. But I mean, right now at this stage, let's cross first.
Today, PK really wants to spice it up. He was like,
well, I mean, listen, it was interesting because I was at a conference with Darren Schneider and a few other. Yeah, we did a little Nick and a few other people, and they all talked about not getting pedal access and rather using direct SFA for these, because rather than jeopardize any of the pedal vessels. Go ahead, you do it. Rather than that. So that's one of the reasons why I said, okay, let's try this. We normally don't do this. We can easily cross with the pedal, but again, our pushability is a lot better from this level. Nope. Nope.
It's probably my 035.
No, it's not 035. It's your Nick is not good.
Oh, well, I went all the way.
Yeah.
Oh.
Meaning
And it's also the fact that at the end of the day, managing this is, it works out quite well, because just a long balloon tamponade is usually all it really takes.
Yeah.
And usually at this point, you're going to be doing some amount of treatment at that disease level anyway. Okay. So even with a prolonged DCB inflation.
So I'm going to go with the vert tip catheter now.
Yeah, so we have the sheet then.
We have one.
We have a vert tip.
Yeah.
Give us another one. Give us another one, Damien.
The ACT was okay?
Yeah, 327.
So we did this on heparin, Roman, and Haroon. So right now we're on heparin. And what we're going to do is we're just going to go up and just cross, and hopefully, once we get closer. Just because I guess
it's cheaper.
That's actually a good reason, but that's not the reason. I think we just were like, we're getting direct access. And
just in case. I mean, not that it matters. You're right. We do all CTOs except for iliacs. We do pretty much everything, almost 100% on Angiomax. But this we just wanted to be, I guess, like I said, PK wants to spice it up, extra cautious. So we do it in heparin. Yeah, but if you manage a heparin well, then usually it should work as well for your anticoagulation.
Yeah. Give me a torquer.
Yeah, it's on.
Maybe do a roadmap so we know where the ostium is. Or no?
Yeah. Why don't you do a roadmap from above?
Okay. Hold on. Too much. Okay. Good. Perfect. Let's 1 second off PK. Okay. Whenever you're ready. Go, Moin. Moin. Inject. Okay. So that way at least we know what direction we're heading to.
Okay. Let's pull this back here. Get the loop.
Oh, Tomo, sir.
He's feeling
You probably
something.
feel type. Yeah, that's what happened.
Okay, that's good.
Nice.
I would go up. Track it.
Just going slow.
Big
loop.
We'll reduce my loop.
Yeah.
Here. Track.
So you can see as another technique, PK is trying to make sure the loop doesn't expand expand big, so that way we'll have a lesser dissection plane to deal with.
A little more.
So it will give us less trouble to re-enter. So that's very important thing. He's
not losing it. I guess now the issue is you want to switch wires. What do you guys want to do now?
Oven 4. I'll do Oven 4 or Oven 8. I mean,
let's go
Oven 8.
Yeah. Oven 4 Confianza here, guys.
I would actually consider I wonder if you'd have a little bit more safety trying to make them meet in the occluded segment. Maybe go with the Confianza from above and below, both.
Yeah,
so that way you're safe far enough.
Let me try from above.
But you're right. Well, we can at least try to get a feel from below if it just pops.
We'll try from above, like you said. This way we can ensure that the ostium is good.
That's Dr. Kapoor.
That's the Confianza.
Yeah. Give me the wire introducer. Okay, Ray, I'm going to need you to put a little positive.
Let me give more light up, but it's nice and soft. Take some more.
1/4 torquer. 1/4 torquer.
So remember, the cap was quite rigid from above.
Okay.
So.
So PK in this case is like, I think they were talking about one of the conferences, like how to numb up the adventitial side so they don't feel it. Do you think that really helps? You know how they go into the calcium, poke, numb it up so that they don't feel the whole sensation that they have, especially in the calcified segments?
Yeah, I mean, I think it's reasonable. Oh. I think it definitely is reasonable. I think it'll pull your catheter back here, Vishal. Keep coming back a little bit.
That's looking nice.
Yeah.
Keep coming back.
Right.
More.
At least the track. It's following our track, which is good.
Yeah, it's a reassuring sign.
Yeah. And I think the catheter itself will create a track. So if we can track it from the top, we can probably enter distally as well. So that way we don't compromise our ostium like Raman was talking about. Because the wire is already in. So this is good that the catheter is following a track. So we just keep going down.
Okay, now we'll come from below. Give me the wire from below. Confianza from below.
Is right there.
Confianza.
I think the whole idea, Raman, is like you said, to avoid the ostium and try to get a reasonable entry point below the ostium. So
as of right now, this guy's living off his profunda relatively well, you know.
Right.
Any kind of compromise
he's
of that.
very symptomatic though. He's very, very symptomatic. There's no question. You know, this guy is. I mean, we could try the Command 18 here as well.
Yeah.
But let me just try the Confianza first from below. Get a Command 18 ready. Yep, we have it ready.
PK, we had mentioned briefly earlier the PQ bypass. You know, it'd be interesting to if you could just speak on that, so all of our people can understand what exactly it is.
Let me get that.
Get me a new one.
Yeah, I know. I agree. I mean, the PQ bypass is something that's not in. The PQ bypass, Raman, as you know, we've done a couple of the cases together, Yumi and Vishal. And, you know, I think that's not necessarily a front level thing for us, right?
Correct.
I think
Yeah,
you and I
that
both agree
I definitely agree on that. Yeah.
You know, we want to do that as a second level after something else fails. So pull your wire back, Ray, a little bit.
Yeah, I was going to say.
Oh, I get the wires
I
here.
got it.
Yeah, let's see here. There you go.
Follows the wire.
That's better right there. Oh, nope. No, there I am through. There you go. Okay, so we cross from below. So there's definitely moved from below.
Don't do anything.
So the question here is now pull the catheter back. Let's see if we can put it in the catheter.
Hold on.
Oh, let me just come off.
From
Just
the
pull
top.
the other, pull the catheter back from the top. Pull the wire back now. Let's see. Put it to the top, Ray.
Yeah, I am. Yeah. Hold on.
Right there.
Yeah.
Pull
Let
back.
me.
There you go. Stay there. I'll get it.
Yes.
You get it.
Oh. Or what we can
Maybe
do.
bring it closer.
Your catheter made us cross from below.
I agree. But
Yeah.
I just don't want to track it across and create a plane.
Just need it from
I'd rather balloon from above, you know? Or we can go with an 018 catheter, like you said. Pull up there.
Mm-hmm.
No, it doesn't want to go.
Let me turn it this way.
Are we in the right?
It's a huge vessel too. So.
That's the problem.
PK, what would be the ways that you would try to confirm that you crossed directly at the ostium? Because we're committing ourselves to whatever passage we took through this level. But what can you do? You know,
I think IVUS is the only way, Roman. I think IVUS is the only way. I really do.
Yeah.
I think IVUS is the only way.
You did have another angulated view that did kind of show that nub very well. Do you routinely take that extra angulated picture again once you cross this and make sure that the wire is actually at that nub and not somewhere more posterior or something like that?
Usually I try, but you know the problem is, as you know, Roman, it's very difficult for us to actually tell where we are. So I think I'm going to do what you said. I'm just going to push it up from below here, and then see if it goes. It does not want to go.
We can snare it from the
interesting.
top.
I think you have to snare it.
Yeah.
And that's not a bad option.
Get a snare. Get a snare, guys, for Vishal. Pull your catheter back.
Yeah. No, that's huge.
What snare do you want, Vishal?
We have 15 first. See. Yeah. Wow. It really.
Here.
Let me
The
spin.
vessel is huge.
So you know what? Let me spin the catheter from the top to make it at least touch. See where it's. If you keep your wire up there, and let me spin the catheter. See if it.
Yeah, it's
So it
touching,
does.
see?
Right. So let me see where it touches, so that way we know it's closest to it at that spot.
No, but the problem is I think the vessel is just too big here.
Yeah. No, of course.
I mean, we're good. I don't think we're that good.
No.
Do you think you guys want to take
There
a
we
picture
are.
in a different
We're
view?
good.
There, you got it. All right.
Yeah.
Wait,
Okay, it's in.
No.
Nice.
where'd the wire go?
That's what we're going to look for. Make sure
It's
we're
supposed to
in the
go where it's
good.
supposed to.
Yeah, so we're in the right there.
I was like,
All right, so we're just
Yeah,
going to
yeah.
externalize the wire here.
okay.
Yeah, I did.
Okay.
I'm going to pull my wire. Hold on, let me pull this wire back. No, I have to pull my original wire back.
That's the reason I'm having so much
Yeah,
resistance.
that's what I'm saying.
Yeah.
Here, Moin, can you hold the wire?
Yeah.
Okay, we're out now.
Perfect. I'm going to pull the catheter
Let me
out.
make sure. Yeah, all right, now we got it through and through, Raman, so we're good.
Here.
Good.
Okay, good. Now you got it. Okay, now you can pull it out.
Okay.
So now the question is, if we're going to IVUS from above then, or we can IVUS from below too. Let's IVUS from below. Get us an IVUS, guys.
Yeah, IVUS is ready.
So once Vishal does that, I'm just going to pull this back, and I'm going to IVUS from below. And to answer Dr. Sharma's question, you'll fix the sheet. Good. Excellent. So
IVUS.
now we're going to IVUS from below. IVUS team ready? Okay.
Flushed.
Another thing is this, these long segment
Here you go.
occlusions, the question always comes back, like where we're learning more and more is that the more metal you leave back, is that, how bad is that really?
So Raman, I guess the question now is, how are we going to treat this? I mean, Haroon, you guys know the data well. But it's more than this has never really been studied. So real world wise, what are we going to do here? So there's the IVUS going up.
So far, so good.
So far, so good. So don't worry.
But unless we're in the dissection, it might give me a little bit of trouble. We'll see.
Let's see. Go up. Yeah.
It's
No
cool.
problem at all. Go
Still
to
in-
common femoral. Common femoral. We're going to go all the way to the common femoral first. All right. Let's go live with
To
the
be
IVUS
honest,
guys into the common femoral.
you're not terribly subintimal.
I don't know.
You're
We'll
pretty
find
good,
out.
actually. No, you are.
going.
This one, I don't want to buckle it.
Yeah.
Yeah,
Trouble.
so-
I don't want to ruin my wire.
All right. So we're going to get another one.
No, we do it
Wait, just
either
balloon
from the top.
first?
Yeah, balloon first. Because
All right. Let's balloon
if
from below.
I kink my
Like
wire,
the
then we'll be in
2-0.
trouble.
All right. All right. Give us a
I-
2-0 balloon, guys. 2-0 long balloon. A 3-0 long balloon's fine.
Hold on. We have to walk in my PK. I'm going to hold the sheet.
Why?
The sheet is
It's already there.
No.
It's hooked.
Oh, that's true.
So we're
Oh,
fine.
sorry.
3-0 long balloon.
Yeah, let's balloon.
Yeah, I think in this case, what I'm trying to get more and more to is trying to leave as little metal behind. So this would be a case where likely would DCB nearly the entire segment. The ostium is very likely going to need to be stented. So I'll probably finish with a drug-eluting stent in the ostium, and probably just try to DCB the rest and supero anything that is still flow limiting.
I think the problem here, Haroon, what are your thoughts on what you would do here? Because I see a lot of problems with making decisions in this area because of lack of data. But I'm curious what you would do here.
Remember, we
think
got a lot of
to
info
do
with the IVUS though, which is
Yeah.
good. A lot of info with that IVUS.
You have the wire, right?
So I think the data for the DCB is very good, the impact and the LIMA LAD trial and the biolux. So it at least needs the DCB. The question is, are you going to
pull the
stent,
wire,
I think,
Chief?
the ostium?
Yeah.
Yeah, exactly.
You
Give me
pull the
rail.
one. There
Perfect.
you're
Okay.
through now.
Wait,
Good. Okay, hold on.
That's what I was gonna say.
Ostium probably, or the SFA.
A lot of pain in the
definitely
thigh?
I give more, but I'll give more. Yeah.
Is there a
All right,
hematoma?
say that
No,
we
it's not.
didn't hear
I
that
mean,
the
it's a
last part you were
posterior
saying. You
side,
said
it's not.
ostium of the SFA. What were you saying?
Yes, so Raman, I think the SFA
Let me
ostium
pull back.
needs to be
It's a
stented, otherwise it's
below.
gonna reach the nose also. What's your
Good,
thought?
good. That's good.
Okay, go up now.
Yeah, once.
Yeah, I mean, I think the risk of restenosis, I think, is definitely a notable concern. I think the more challenging part is if you DCB and dissect at that level, I think the challenge would be like how are we going to be able to ensure we actually properly nail the ostium. So my treatment of the ostium would be more for trying to ensure we nail the treatment appropriately, more so than restenosis at that level. I think this is an entire lesion that is very, very high risk of restenosis, regardless of the therapy that we end up doing, because the data even at
14.
2, 3, 4, 5 years, regardless of the therapy, is still not like anything greater than 70%. So it's the restenosis rates are still the main issue here throughout. But the early failure is what I'll be trying to avoid, which would be by missing the ostium.
Well,
No, I think I agree with Raman. I mean, I'll definitely send the ostium for sure to make sure there's enough. I mean, the question about the body of the vessel, which is the mid and the distal SFA, I would just DCB and spot spend if I have to, decreasing the metal load there. And we know the drug data, DCB is good even in CTO. So I think we can try that.
Yeah,
So
to be
definitely
honest,
one of the
I'm
options.
just looking forward to our new drug family. You know,
The sheet
Well,
is
sheet,
cheat
sheet.
sheet.
Ooh.
Oh, balloon.
Vishal. Okay.
Hold on.
Okay, we're gonna have to redo this.
No, wait.
No, sheet's out. Sheet's completely out. Okay, give us a micropuncture sheet, please.
Well, this actually wouldn't be a bad time to maybe just recross and just get the wire distally now. If we
We
did
can go up
lose
and over.
Yeah, but let's put a
Yeah.
sheet in. We got a 5 French hole there now, 4-5 slender hole.
Oh.
Actually, you can just give me a 4-5 slender. Just give me another 4-5 slender. Another 4-5. It'll go on this. Just need me the 018 dilator.
In your experience,
The 018 dilator, right?
what's the incidence of pseudos?
This is the
at
035
level?
dilator. Oh, that's what I need. That's what I need.
Okay.
What's up, brother? I'm sorry.
So in your experience, what's the incidence of pseudos with these direct SFA axes?
Very, very low, but this guy is having a lot of pain. Elizabeth did say that he's having pain, and Vishal did lose the sheet. So, it's definitely something to worry about. So I got to blame Vishal for something every case. No, I'm joking. But it's not going?
No, we're through.
It's in?
Yeah.
Okay, now take out the dilator. Good. I'm just teasing Vishal, of course. All right, DSA guys, let's see what's going on. All right, let's see the flow now.
Nice.
Okay, good. Remember, he had that thing there, so we
Correct.
definitely have flow. So now we can come from above and cross from above. So what we can do is I can push the wire, Vishal can pull the wire from there, and then we can just introduce a catheter. Let me push the wire as you pull the wire. Ready?
Yeah.
Go. So give us a catheter from above, guys. Yep. We have it.
Moin, hold us.
Yeah.
Keep pulling.
I have.
Keep going. You got plenty.
Good. Right there. Coming.
Okay, come. All right, let's put a catheter from above now.
Give me another mosquito.
Mosquito for below.
Yeah, got the
Okay, so now let's get the IVUS ready, guys. We can do the IVUS from below. IVUS. So we're going to do the IVUS from below now, Roman.
Yeah. I'm just going to put a mosquito once he's done with the IVUS.
So the question is, would you stent from below or above, Roman? And
Above.
Haroon.
Above.
I think from above would be better.
We have to. I mean,
Why?
if you want to.
You have more control from above.
Well, you also only have a
not for
5
the
French
osteum.
system.
Well, 5 French system. Remember the system.
French
Yeah, we
is
can
the-
change to a 6 French. Right? All right, so we're going to go to the osteum here. You can always change. Okay, go to the comment. Okay, why is it so bright, guys?
Nice.
Could we please show the IVUS?
Yeah, no, he's
This
just
very,
making
very
the better
bright
color.
IVUS.
Here, take this.
Very bright IVUS. Thank you. Okay. All right, record. So this is the common femoral. Very slow here. So let's see the profunda bifurcation. Still common femoral.
Almost, sir.
There's your bifurcation. Keep coming. All right, looks like we're not really subminimal. Are we? No, it's good.
It's perfect.
Now we're in the
Looks
SFA. Yeah, it's intraluminal. Now we're obviously.
No,
Now
we're
we're
still
now we're
still,
subintimal.
still
no,
yeah,
it
yeah,
is
yeah,
just a
kind of
little bit, just a little bit.
Yeah, just next
Barely.
to it. Yeah. Just
This is a very, very good cross. I mean, you're
See,
we're in and
barely
out.
subintimal.
Now we're
Now
in the
we're-
lumen.
Now we're in the lumen.
See?
Yeah.
You were
It's
just
now actually
subintimal
in-
there. Yeah, no, this is I think that this actually goes to speak to the point about why retrograde crossing sometimes saves you so much time. Because I feel you spend such. I mean, this is a demonstration here. You're a little more subintimal. This is closer to where
Yeah.
you had access. It looks like.
No, not
No,
quite.
still
no,
way
we're still
far
way
off.
above.
Oh, so way
But
above.
we're just, like you said, just next
Yeah,
to the vessel wall, in
surprisingly
and
close.
out like how we
Yeah.
do.
Some of these antegrade crosses you have, you'll loop around the entire vessel, and you'd be
Yeah.
subintimal, almost adventitial at times. This is a very clean cross, and you
Raking
spend
the sheet.
the majority of your time just interluminal,
Now we're
subintimal.
completely
Yeah,
out.
so now,
Yeah,
now
we're
we're out.
completely out.
That's
Yeah.
okay.
All right, so now the question is
Okay.
we're committed to a stent.
You can
so you want a DCB then stent? What do you guys want to do?
Where was that distal portion we were looking at? Was right by the axis,
together.
correct?
Right by the access, yes.
Yeah. So I think it would be my plan would be DCB the distal proximal segment towards the axis,
We don't need
do a Zilver or Illuvia up
Yeah.
north, and then
It's on.
Supera, whatever needs to be done
Pick it up.
distally.
Okay,
I would still
so
give it a
what-
chance. I would still give it a chance to avoid.
One approach is to DCB and Supera the distal and Illuvia the proximal. What about you?
No, I agree. I mean, I would DCB the whole segment. The distal segment of the adductor canal looks definitely diseased. So Supera that, and then ostium, I'll put a stent irrespective of how good it looks. I mean,
Okay, so let's cross from above and externalize the wire. So get us let's vessel prep this before we DCB it.
Yeah.
So get us a 6.0 Dorado, guys.
Would
6.0
anybody?
long Dorado. Give me a
So- We just
a,
measured it, and it was
a
closer
bird
to
tip?
a 5. No.
Was it a 5 or a 6, my friend?
We have
He's a big
work
guy. I can't imagine it being a 5.
yet. Not yet.
Bird tip, guys.
Yeah, it would need at least a 6.
At least a 6.
He's not a small man, so I
Mm.
wouldn't put less than a 6.
Where did we measure?
Uh-huh.
It was 5.
Remember, it's a
It's
hibernating
a
vessel.
5. You're
so-
saying it's a 5?
No, but how's the ostium? Remember, it's a hibernating vessel, so you can have a 4 or 5. Yeah, I would doubt it's a 5.
I mean, I would do at least a 6 in the ostium.
6, yeah,
That's for
definitely.
sure. But like for the rest of the segment, I mean, do we know what was used on the contralateral side?
6.
6s.
Uh-huh. Go ahead, Michelle.
Good.
You gotta feed it. You have it? Oh, he has it. You can pull it to you.
Good, good. I have it like
Now, at what point would you plan on removing your SFA sheath?
Right now.
And right
Once
now,
we get the
very
wire
good.
distal, we're gonna pull the SFA sheet, put a catheter down, and then put a 035 wire down, and then do our 018 wire, and then do our work here. Here comes the distal. Okay, now. Okay,
right at the
okay.
sheet.
Now right at the sheet. Good.
right
Now
there.
we're gonna lose the wire here. Give me an 035 command. Give me a command 018 now. Or command 014 is fine. Actually, 018 is good. And then give me a long 01860 balloon, one of the BD balloons. Get rid of those wires.
Is,
I'll give it 1,000. Yeah.
Yep.
Just to keep it about 300 in this case.
So Raman, we're just switching out for command 018. I'm looping it so this way it doesn't cause any issues. You know, the command is pretty difficult to loop, and I'm trying to loop it good here. Okay, that's pretty good. So once we get the 6.0 balloon down, we'll just go across it and tamponade this thing and then be done.
Yeah.
There you go. Okay, that's
Beautiful.
done. So the loop is down. Now we're going to walk this out. 6.0 balloon, guys. 6.0 long. Yeah, long as you got is fine.
Wait. Yeah.
Okay.
You're gonna
You go,
put
AP.
this wire down all the way into the 80.
Yeah, that's
It
what I'm
doesn't
trying
matter
to-
where it is.
Well,
It's below the knee. That's all I care. Let's clean up here, Moeen,
Yeah.
please. You got to keep up with us.
Yeah.
Okay, 60150 going in now.
What adjunctive therapy are we thinking about?
Well, the question, I don't think we're going to do atherectomy here. I
Yeah.
don't think there's any need for it. I think at this stage, what we're going to do is we're just going to go
I
ahead
have
with
it.
an 018
I have
60
them.
pull. And then once he gets across the sheath, I'm going to pull the sheath out. Uh-huh.
raise my table up a little bit.
Uh-huh. So you know the BD balloons lead with the, that's fine. Now we're going
After
to
the
go,
sheath.
we're just going to pull the sheath out, ready to go
Oh,
up.
hold on, first ready to go.
Uh-huh. Come forward. Uh-huh. Hold on. Ready? Ready to go up. 1, 2, sheath out. Ready?
Yeah.
Go.
going up.
Uh-huh. Uh-huh.
4,
5,
5.
6. What's nominal here, Dame?
8. 6.
6 still bleeding.
I think that's probably
Okay.
also my trachus,
So
but I'll hold
6.
pressure.
We'll just hold a little pressure here. We're going to give a little injection. Look up,
Correct. I was going to say you can do an injection. Yeah, it's a clue.
No bleeding.
Yeah.
We'll do it again here since I shot too quick there, Raman.
I'm gonna let that one slide.
And no comment. All right, very good. Okay, good. All right, so we got this. Okay, now let's talk, guys. So while we let this tampen out for a bit, now talk to me about what you're going to do. So we have one vote from Raman for DCB, followed by Supera below. For you, what do you think? What do you think, Haruni?
So my opinion is like I agree 100% with Raman that I think we should do a DCB and see how it looks like. If you still have significant dissection, you should consider putting in a bare metal stent followed by that.
Followed by DCB. So you put a Supera or a long bare metal stent. Okay. Vishal, yourself?
No, I agree. I mean, I'll just DCB the whole segment, and then we'll see how my ostial and the distal reconstitution looks. And of course, then spot stented depending on how it is. If my distal looks fine, I'll just stent the ostium. But if not, then we do a Supera in the adductor canal, and then proximally we do a Illuvia Zilva, any drug-eluting stent.
Okay, fair enough.
I think the only thing which I'll just
guys 60250.
I think the only thing which I would add here is just that if I understand we're not doing atherectomy in this case, but I think it's important to consider what about the IVUS drove you to that decision, because I would say that, I will argue the counter that the IVUS would drive me to do some form of debulking, whether it's atherectomy, atherotomy, something, considering the fact that we spend so much time interluminal, which is mostly just like dense plaque.
Right.
I would have probably performed something, whether it's directional, if a 5/0 serenator across the entire length of it, something. But what drove your decision to skip that?
Well, for me, I think if you look at the data, I mean, very clearly the data with vessel prep is lacking.
Correct.
I mean, right now in these long segment lesions, we have the impact, long study. We have the Silver, Japanese PMA. We've got the Supera long, but none of those included vessel prep other than definitive AR, which is 18 patients. So to me, I think at this stage, you could definitely do atherectomy. I don't think it's wrong, but I think the data is still out on that, and we still don't know what the right thing to do is. Right? Yeah. So I think at this stage, I think to me here, I think we'll go ahead and it's not going to change my therapy in any way by doing atherectomy. I don't think I'm not going to stent because I atherectomize. If that was the case, then I would do atherectomy. But I think this vessel, especially distally, needs a stent. And ostially, as you know, the mode of failure is always at the re-entry point. So at this stage, if you put an ostial stent and a distal stent, what difference it does make? Just put a full metal jacket. I mean, I know that our data is not the best with full metal jackets, but our data is not the best with any of these. Even with impact long, there's 40% provisional stent rate that occurred. Give me the 035 long 250. Yep.
So, so you're okay to commit yourself to stenting the entire segment, ostium to access?
Yeah, I am. I hate to sound like that, but I really am.
Interesting. Okay.
I really am. I think in this case.
So Dr. Krishna,
I guess you're right, Ron.
Question for you.
Go ahead, Cameron.
So go ahead. So the IVUS, did you have any element of calcification on the IVUS that you saw?
You have to give it to.
There was a trivial amount towards the axis.
Yeah. So then it doesn't really helpful to use shockwave or any other plaque modification.
Okay,
yeah, I mean, the question which I would have is because I've PK, your expertise in this field is renowned, but I feel as if there's a lot of extrapolation from the coronaries, where again, similarly, there's not any any robust data to show that rotational atherectomy, orbital atherectomy, or anything does anything overly significant. It's more of just what people's comfort. Even in patients who have very severely calcific disease, there has been only just a handful of trials that have shown some benefit. But there is a lot of just kind of like cultural around the idea of debulking, which I think is, as an interventional cardiologist, we are very quick to kind of transition that to our endovascular work. And I myself have a pretty hard time removing that thinking process, and I find myself very often choosing atherectomy, atherotomy in adjunct to my treatment. And I think this the IVUS in this particular case would push me very, very strongly to do something. And in the hopes of saying that once you do your DCB, you won't have as much vessel recoil, you won't have any severe vessel dissection or so on and so forth, thereby limiting the amount of stent you're going to be leaving at the end. But if you're able to, if you feel able and confident in the data or lack thereof data to speak towards full metal jacket versus a DCB and 4 or 5 year outcomes, I mean, then it's a moot point.
Balloon broke.
Did it rupture?
Yeah, well, yep. The ostium is very tight. So this more evidence to show that the ostium 100% needs a stent.
Yeah.
Yeah. And remember, I mean, you're absolutely right. It also depends on the length of the stent. Let's say you want to stent the distal part and the proximal. But if it's short segments, then of course I would not go for a full metal jacket. But if you think there are 2 stents are long enough that the gap is so small, then it's not worth leaving that gap.
Long DCB.
Because that'll cause you more trouble with those islands of non-existent stent, especially with an ISR and all those things. So then when we do CTO, like Raman and Kamran know, it's like between the normal segment between the 2 stents, it becomes horrible, especially when it's CTO to cross in and out. So in those cases, I agree with PK, just do a full metal jacket, get away with it. And
listen, what we're going to do, I think you guys are all right. These are all excellent points. I think what we're going to do is we're just going to go ahead, and what we'll do is we'll go ahead, put the DCB in, and then we'll decide.
See what it looks like.
Yeah, see what it looks like with IVUS, and then take it from there.
Yeah, I think
it's reasonable. Go.
Hold on 1 second.
Now, PK, how often are you in these CTO segments post-DCB performing IVUS and using that as your decision-making process as opposed to the angiographic results? I think we all know that after we do the angio, things may look good, and then we put the IVUS down and things look not very good.
All the way down, Vishal.
Yeah.
Yeah, I agree with you. I mean, we're using a lot of IVUS, as you know.
I think
I think our IVUS use is some of the highest in the country. The problem is, again, there's no data to support what we do. And the idea, I think is that, okay, we do the IVUS. What's nominal, guys? We do the IVUS to decide whether we have significant recoil.
5.
Because 5 is nominal?
Yeah. It's a 250. It's 5 nominal.
So I think we know that recoil is the one predictor of restenosis that we've proven in our study with the impact database. So if we have any significant recoil, then I think we take care of it. So I think at this stage he's feeling a lot of pain. So we just did this is a 60250, and it's at 6 atmospheres, and you can see there's a lot of recoil here. And the question is that really gonna stay open in the long term? So what we're going to do is we're going to get another 150 DCB. We're going to do the ostium, or do you want to just silver the ostium? Because that's another way to save cost if you just silver the ostium. What do you think? What do you guys think? So I think at this stage, what we'll do is we'll leave this up for 3 minutes. You got the timer on, guys? Yes, 36 seconds. And then what we do is after this, we'll just take a silver the ostium, and then we'll IVUS everything, and we'll see how it looks, and then we'll decide what we're going to do distally. I don't think you're going to be able to get away without doing a full metal jacket, in my opinion. But we'll see. We'll see.
I guess the other question is that, like, sorry, Vishal, go on.
No, sorry. I was talking about if you're thinking about a full metal jacket, then we probably, if you want to do the ostium, then you take a full length Zilver or an Illuvia, whichever you like, rather than taking a short segment and realizing, oh, I want to do a full jacket. Now we ended up adding an extra length.
If you look at that last picture that I just kind of did
the longest are 140s.
Yeah, the way how the balloon was inflating, I think, is the point that Pete is making, is that there's this area where it seems to already while the balloon is actually already inflating.
Yeah,
I think
that's the segment on the IVUS, like Raman, you showed, that where we were really subintimal. I think that's what causes the stretch and everything else.
See, look at this right here. You can see the mid segment is not. That's where you need a Supera. So I think you do a Zilver, and then you dilate this with a 6.0 or a 7.0 and put a 6.0 Supera, and you're done. 6.0 150 Supera.
So why don't we put the Supera
Let's get the Zilver first.
I think this becomes an interesting point here, right? Now, if at the end of the day, the cost effectiveness is a very important issue. Even more so if you're working in an OBL setting. You know, if you feel comfortable going up front with a full metal jacket approach, the cost of the DCB is essentially gone, because you would just say you're going to take 2-3 long stents and you would just stent the entire thing to try to avoid the cost of having multiple drug-eluting stents.
Get us a 140 Zilver, guys. 6.0 140. So we're going to stent the ostium with a 6.0 140, and then we'll see. Yeah. And then we'll do that first, and then we'll take it from there.
How was Macanudo?
Oh my God, I wish it was Macanudo. You know,
PK. I wish. Raman is really poking PK just to spill out the beat. He's like, He's just like throwing those curveballs right in the middle just to catch him off guard. Like, oh, and he goes, yeah, it was good. Oh, there it is.
No, it was actually Dr. Kapoor.
Uh-oh.
Yeah,
Raman knows how to go to McAdoodle's. Yeah,
No, Dr. Kapoor. So Dr. Kapoor and I were at a wedding last week, and Dr. Kapoor had a scratchy throat, and I was near him, and he got me sick. So that was it.
The new variant B749, some weird thing.
It's a D749 a la VK. It's a la VK. Down.
Good, I was not in the same flight with him.
So there's only one person to blame. I usually blame Ray, but this one I can't blame Ray. Can you fix the sheath, Ray? So he wasn't around on that one, so I can't blame him. So Ray's fixing my sheath here as we come out, and then we're just gonna go with this stent on this 018 wire.
What's your distal of the wire?
Arun, what's your opinion on this the full metal jacket versus spot stenting approach? Like how do you approach these patients?
So the way I do it is usually if it's a long segment CTO like this one was, I usually try to get away with without any stenting. So DCB it, and then except for a short stenting at the entry and the exit of the CTO. But in this case, like you were also talking about earlier, there's so much stenosis. Balloon dilatation already tells you that this is not going to stay open if you don't stent it. So for this specific case, a long stent would be a better option, in my opinion.
Perfect. Go. So we're going to stent this. Vishal is just going to drop a quick stent here, and then we'll worry about the rest in a second.
Yeah. Another interesting thing is that we know the long-term data for nearly all PAD patients, regardless of the interventions. The concern is always restenosis. These patients are frequent flyers, and they're going to be frequent flyers no matter what we offer them, really. PK, how do you approach the conversation in the clinic? How do you explain to them that that there is always going to be a chance that they're going to have to end up coming back to get.
I mean, Raman, I think like this gentleman, he has to stop smoking. He knows that, and he's he understands how he feels is because of his smoking and his concomitant risk factors. Obviously, these stents are gonna probably reach stenosis at some point, and so therefore, is this deploying?
I'm just going slow. I don't want it to jump. You remember, there's it's a long stent.
There it is.
It's coming. It's just.
There it is. Okay. I would probably go in a little positive.
Yeah, that's exactly.
A little positive.
Yeah.
Positive.
Mm-hmm.
Good.
That's good. Yeah.
A little positive.
That'll be good.
That's good right there.
I would like to have like a couple of cells over.
Yeah, he's gonna go negative for sure.
Yeah, exactly.
Yep. Now a little negative. Hold a little negative. Negative on your left hand.
Yeah.
Yep. Good. Yep. Perfect. All right. Good. Very good. So that's done, and then now we're gonna go ahead and look at the distal, and then decide what we're gonna do. So this is well expanded for sure. Ray's just fixing the sheath for us. Thank you, Ray. Give us a Dorado now.
Oh my God, sorry.
That's good. Let's do a DSA here.
Mm-hmm. Yeah.
A 60150 Dorado.
60150.
Oh, wait. We can leave it.
Actually, looks very good.
See, Raman, what's that osteo DCB? We're done.
Looks good, Raman.
Yeah, looks very
why
good.
not? Yeah. Let's do an
Let's take one more.
Are you sure? Are you sure?
Let's take one more distal shot. Yeah. See, Ivis will, exactly.
Ivis will tell us not to do it.
Ivis will tell us to do
it.
it.
Just to send the whole thing.
Yeah.
Yeah.
We save the money. That's it.
Oops.
Oh, wrong way.
Okay, good. All right, ready?
Ready.
I think we leave it, man.
We'll leave it.
I don't think we should Ivis it. I
agree. We don't have to be over it.
We're just gonna post dilate the prox, and then we're gonna leave it, right?
Yeah, let's take the osteum picture.
Let's
we
take
haven't
the
taken
osteum
that.
shot.
Yeah.
I think we leave it, Raman. Right?
Yeah.
It's not perfect,
looks
but we're
very
not going to
good.
get it perfect.
No, we're not going to run for medal.
So those at home, I mean, before we sign off, well, we're going to go post-dilate to proximal, and then we're going to leave it, obviously, with any thrombotic, antiplatelet agents here. Raman, anything that you would do different?
I mean, he was on this. This would be a guy for me with his ongoing smoking. Would be on a aspirin Xarelto 2.5. I'm a big fan of that.
No Plavix though. With the DCB,
you can give him like a 1 week of that. Yeah.
With the DCB, okay. Well, I think. What about you, Vishal? I would probably do Plavix Xarelto.
Yeah,
right?
yeah.
I'd probably do Plavix Xarelto for 3 months, and then switch him to aspirin. But I think definitely he's going to need some Plavix because we really don't have any data regarding that at this stage. So that's what we'll do. And as far as follow-up, Haroon, how often would you image him? How often would you follow him in clinic?
Yeah.
So I would see him in a month, and then from there on, just make the decision if he needs to be seen every 6 months or 3 months.
Well, considering he's your patient, that's why I'm asking, right? So
yeah, so that's the plan. So see him in a month.
That's the plan. You need 035 wire.
Yeah,
035 wire,
in a
guys.
month, and then take it from there.
All righty. Well, wonderful, Raman. Thank you. I want to thank Vishal. I want to thank Moeen, and I want to thank our team and Ray for getting this quick case together. Thank you, Haroon, for providing us with the last-minute case. And we'll sign off. And remember, Raman, we changed our dates in December as well.
Yes. So.
All right. Thanks, guys.
Thank you guys very much. Thank you for joining us today for live from Mount Sinai in this great, complex SFA CTO case. Very great discussion. We look forward to having you. And for our Christmas time, we'll be a couple weeks early. So you'll be joining us again on Wednesday, December 13th. And we'll be looking forward to having you then for our final showing of 2023. Look forward to seeing you soon. Bye-bye.